call our next presenter up to the stage now, Dr. Julia Sawatzky from the University of Alberta.
All right. Hello, everyone. I'm here to present our research today on First Nations status and 72-hour return to the emergency department, a retrospective cohort study. My name is Julia Sawatzky. I'm a third-year emergency medicine resident at the University of Alberta and received some funding from Acute Care Alberta to attend this conference, but otherwise have no conflicts to disclose. And I'm here today presenting with my research supervisor, Dr. Patrick McLean, who's a senior researcher at the University of Alberta in the Equity and Emergency Care Research Group. He receives a salary from what was formerly Alberta Health Services, now Acute Care Alberta, and has some grants for his research that are disclosed on this slide as well. We're also joined in this work by Leah Bill, who is the Executive Director of the Alberta First Nations Information Governance Centre. She was not able to be here with us today, but has provided some content by video that we'll show in this presentation. And we have a wonderful group of co-authors who contributed their time and expertise to this project. This research group has been working since 2017 to both qualitatively and quantitatively describe disparities in care that exist for First Nations patients in the emergency department in Alberta. And many of these partnerships precede my time with the project, and I really gratefully acknowledge the time and energy that has gone into building good relationships based on reciprocity and trust that allow this research to proceed in a meaningful way. And to that end, on the next slide, Leah Bill will introduce some of the concepts around ceremony and research that were foundational to building these partnerships, and then the OCAP principles that guide the work.
Ceremony was an important component to the research process because it allowed for cultural practices to be integrated into the research process. Ethical accountability is the way that we as First Nations see an important role of including ceremony. The ceremonies actually provide the parameters by which we participate in ceremony, but how we conduct ourselves as well. And it was also became an important part of the healing process. It promoted healing and reconciliation within those spaces because it created a sense of safety. The other component of it was that the ceremony also set up the space in such a way that it supported power balancing, so that there was no sense of one having more power over the other, but that there was an equity in the opportunity to express their stories in such a way that they were also experiencing healing. OCAP has always been a very important part of our mandate at AF&IGC and the formal research agreements that we have with all partners, be they with academic and or with communities, includes OCAP within our formal research agreements, as well as it specifies roles and obligations related to ownership, control, access, and possession of data and information. Alberta F&IGC is the data custodian for qualitative data, as well as some of the quantitative data, but more importantly, the qualitative data is stewarded and held by Alberta F&IGC for communities. We currently have a data platform now that allows for communities to place their qualitative data on that platform and have partnerships with the researchers to be able to work with it, where they have ownership, control, access, and possession of the data themselves, and decide who and how that data is accessed. Communities own the qualitative data, however, we support and assist in the stewardship and the custodialship of it. In this project, there was a co-interpretation that took place of the project data where partners and elder knowledge holders had opportunity to review the analysis and then provide context to that information in order that a well-rounded story and picture could be ascertained from the data itself.
So returning to the emergency department within 72 hours of a visit is an often cited health systems metric thought to reflect things like access to primary care, inappropriate follow-up services, inadequate discharge instructions, or dissatisfaction with care at the first visit. And in this study, we aim to examine 72-hour return to the emergency department among First Nations and non-First Nations patients in Alberta. Additional analysis from this project examined deaths within 3 days of an emergency department visit among those same groups. This was a retrospective cohort study done with provincial administrative data from Alberta collected between 2012 and 2017. The emergency department visit data came from the National Ambulatory Care Reporting System, and we did return to the eMERGE analysis on only discharged patients. First Nations status was determined using the Alberta Healthcare Insurance Plan Population Registry, and mortality data for our death analysis was drawn from Alberta Vital Statistics. Over 9 million visits were analyzed as part of the return visit analysis, and we found that 15.7% of First Nations visits resulted in a return within 72 hours, while 13.5% of non-First Nations visits were followed by a return. 6.2% and 7.0% of those visits for First Nations and non-First Nations patients, respectively, were admitted to hospital on that return visit. And we think overall this shows us that a certain percentage of those patients who return go on to require admission, and yet First Nations patients were presenting for the return visit more than non-First Nations patients in this data. When we did a multivariable regression analysis that allowed us to adjust for patient characteristics like age, sex, comorbidities, and socioeconomic status, as well as visit characteristics like CTAS, facility type, arrival method, and time of day, we found that First Nations patients had 1.12 times the odds of return to the eMERGE within 72 hours than non-First Nations patients. When we looked descriptively at deaths within 3 days for these visits, it was overall a very small number of visits that were followed by a death, and there was no difference between the groups. So 0.005% of ED visits in each group were followed by death within 3 days. But then when we looked at this by age, First Nations patients were disproportionately represented among the deaths within 3 days. So First Nations patients make up 11.1% of all pediatric ED visits in this data, but 18.2% of the deaths within 3 days. And for adults under the age of 55, First Nations patients made up 10.7% of the adult ED visits, but 16.9% of the deaths within 3 days. Oh, sorry, I'm just going to skip that slide and move on to discussion. So First Nations patients overall in our analysis had higher odds of returning to the emergency department within 72 hours than non-First Nations visits, and this difference could not be accounted for by geography or other patient demographics. We think this could represent distinct population health needs between the groups, disparities in access to care or follow-up, inappropriate discharge instructions or misdiagnosis and premature discharge, or dissatisfaction of care received at that first visit, or a combination of these factors. Here we draw in a quote from the qualitative work done by the same research group that helps to illustrate the commonly described experience that patients reported of needing to seek care multiple times in order to receive a diagnosis or treatment. So following a car accident, this patient said, he, an emergency doctor, said, "I checked all your records and everything." He said, "There's absolutely nothing wrong with you." I said, "What?" "There's absolutely nothing wrong with you." "That's very strange because I'm hurting and I'm supposed to be the one knowing that there's nothing wrong with me." Then he just turned and walked away, so I was hurting the next day. This patient disclosed that on seeking care elsewhere, it was discovered that they had a bleeding kidney. These findings are broadly in keeping with findings of disparities in care for First Nations patients. By this group as well as by others, so Boss and colleagues in Alberta demonstrated that First Nations patients reported lower quality emergency care than patients who identified as white, and this was largely explained by their perceptions of the compassion that providers showed. Our analysis is limited because some First Nations members were inadvertently misclassified as non-First Nations because of the way that the data was pulled from healthcare premiums, and as such, we think that we probably underestimate the true relationship. Our data set only contains data up until 2017, and we cannot draw firm conclusions regarding whether the return visit could have been avoided by changes to emergency department care. Nonetheless, there are many implications and future directions to come from this work. So certainly there are system-level interventions like improving the availability and accessibility of primary care, health-related transportation, especially for rural and remote populations, and culture and language-appropriate discharge resources. And then within the emergency department, where many of us work, we should strive for Indigenous health, cultural safety, and anti-racism training for all providers, data collection around performance metrics like return visits that are linked to accountability mechanisms, and above all and throughout all of this work, partnership with Indigenous communities in the co-design of safe and appropriate emergency care. Further research to that end should seek to explore what factors drive representation. So that could include either qualitative or prospective research that captures variables like readiness for discharge, satisfaction with care, or the appropriateness of the discharge planning at an ED visit. Thank you so much for your attention, and I welcome any questions.
So we should have time for one or two questions. I think I see someone coming up at the back here. I have so many questions about how you built these relationships and this trust, and I think it's bigger than we can even address probably here, but I will just say hats off and respect to you and your team for building this trust and for working with your First Nations populations and partners.
Thank you.
I think there's a question.
I was going to start by saying the same thing. Congratulations, and it could have been so easy yet wrong to do this with large admin database without engaging them. My question is, I wonder if it's conceivable that your findings could also be underestimated because there's a feeling that at least the First Nations are more likely to experience or at least perceive their first visit as being less than optimal, which could lead them to even less return visits because they don't want to experience this again. So the fact that you found that they are more likely to return in spite of this might be an underestimation even of that problem.
Yeah, absolutely. That's a great comment. And I think the qualitative work that's come out of this group has really demonstrated that experiences of racism and discrimination in care does prevent people from representing. Yeah, so I think it's absolutely possible that we're underestimating for that reason as well.
Maybe, Julia, just following up on that, I wonder if you've had a chance to take a deeper dive into any subgroup analysis of distinct groups that might be driving or skewing this, like high users or other groups that might be, like I said, like skewing the data.
Yeah, for sure. So we had a really brilliant biostatistician, Rhonda Rosacek, work on this project as well, and she helped us to build models that did account for frequent users, and so the layers of the model were at the visit level, but then also accounted for each individual patient in order to account for repeat visits. Some of the, we also did interaction models that were very interesting, and one of the key findings from that was that there's a large difference in rural and remote areas. So we looked at small facilities outside of the metro area as compared to larger facilities and found that there was no increased odds of returning to care in those settings for non-First Nations patients when there remained this increased odds of return for First Nations patients. And about 30% of 30% of emergency care in Alberta is provided in those settings. So we think that that's also a significant driver of these findings.
Really great work. Thank you again and congratulations.
Thank you.